14 GP practices in London. We're providers of urgent care services and out-of-hours services. And we're the National Practitioner Health League for sick doctors and nurses who have addiction problems or mental health problems. And we started the primary care gambling service 5 years ago. Sorry. Is it up, Drew? Just the middle button? Oh, you'll do it. Lovely, you'll change them for me. Thank you. So established by Dame Claire Gerarda. Claire is, she was the previous president of the Royal College of GPs. She recognised the need within primary care, and we had two main aims: to provide timely treatment for patients suffering from gambling harm, and to educate and improve the responsiveness of the primary care workforce. And Dr. Emma Ryan will be talking about all the work she's done with healthcare professionals over the last 5 years. We are a GP-led service, and we take a complete multidisciplinary approach to every patient we see that's referred either via our own referral routes and nationally. We're a national service, so we take referrals from all third sector, voluntary sector organisations, mental health trust, and we have a separate, it's not a contract, a separate arrangement with the Ministry of Defence to primary care, particularly with primary care Ministry of Defence services. So, we're made up. We started as COVID hit, and we never ever thought we'd see any patients within the primary care gambling service. And there was 3 of us for many years. We're now a team of 22, so we have medical directors, deputy medical directors, psychiatrists, GPs, therapists, a full mental health nursing team who do a large amount of our assessments. There's general nurses in the team too. Non-clinical coordinators, because a lot of our work is liaison work too. We treat the gambling harm, but there is a lot of liaison work because some of our patients have high acuity mental health needs too. And we have operational managers. Our data analyst is key. We have tracked every single patient on what we call our tracker for the last 5 years, and we've seen nearly 3,000 patients now. And so that is our workforce, and we have pharmaceutical cover. All our practices have pharmacies sitting in them, so if we choose to prescribe, we can call on them for their expertise in that area. So our patient pathway. Next slide. So there are many ways that patients reach us. Our third sector colleagues, and I'll go through the governance we've worked with our third sector colleagues, the LMD, and any other services that are accessing the primary care gambling service. They can come to our website. We've got a secure website and a secure link, and they come through. And we know from the NICE guidelines, so if people are okay with the NICE guidelines, that people cannot wait once they come through our service. So our time for assessment is 2 to 5 days. That's notwithstanding someone picking up and answering the phone. And it's even less really to therapy. And I'll go through our therapeutic options and what we use within the primary care gambling service. And down it's right-hand side, I think, for you guys. It's left-hand side for me. These are all the people we work with, and many more, because in recent years, mental health trusts are now referring into us. GPs are, because of the work Emma has done with the GPs and healthcare professionals. So that's just a patient pathway, and this pathway has worked really well. We have 50 to 70 new patients a week. We have a mental health nursing team that will do at least 2 assessments a day, and we don't have a waiting time. I was looking at numbers yesterday to see how many people were on our waiting list, which isn't a waiting list. There were 48, and all 48 of them will be assessed by our mental health or clinical team this week. So, as an NHS statutory organisation, we have to have very, very clear governance arrangements in place with our third sector providers. So we have memorandums of understanding, confidentiality agreements, data protection, impact assessments, secure data transfers. We have a really well-designed risk management system, which is progressing further with a digital risk stratification tool that is being trialled at this moment in time. We have clear responsibilities of where care is managed, where accountability starts with one service and stops for another service, and vice versa. And we're a great believer in that when someone comes to us, as they come to us, we are already discharge planning and looking for sustainability with gambling harm back to our third sector colleagues. So it isn't just about getting treatment and that's it, it's all done and dusted. That's not it at all. We need to sustain this. So we've got some brilliant organisations out there with aftercare programmes that we use across the country. And it depends where people are coming in from, because we get patients from Scotland, we get patients from Wales, so we try and look at aftercare geographically. So our assessment process takes around an hour. Our mental health nursing team, our GPs and nursing team will undertake an assessment. As I said, it's 1 to 5 days. There's no waiting list at this moment in time. And it's a holistic approach. You can't just look at gambling because so many people have undiagnosed comorbidities, reoccurring needs, mental health needs, social isolation and trauma. And our model of care is not to fix all that, that's not what we're here for. It's to have a really good pathways in place to liaise with the people that need to be involved in the care. And as an NHS organisation, it's much easier with secure emails and things like that to get an answer perhaps from a GP or a mental health trust and move someone's care forward and look at it holistically. We do a full holistic assessment. We don't just concentrate on gambling. And our treatment planning is not done in isolation. We have 2 multidisciplinary meetings a day, and this is why it's so important to get people into treatment so quickly. If we waited to the end of the week and then tried to sort out our therapist, etc., that's another week. So we have dedicated time every day to have our multidisciplinary team meetings. And we also manage risk, because there is risk. There are patients that are suicidal. We don't have an exclusion criteria apart from active psychosis. And so we have a very, very clear risk management process. We have a risk register that's reviewed every week or as and when within that week if risk is raised or declines. So our multidisciplinary approach, I've told you already that these meetings take place. No one single person makes a decision. There is really very clear dialogue and rationale, and we're using the 5 Ps, the precipitating factors of gambling, to decide on best treatment. We know the NICE guidelines and what they say and what they're advocating, but within our service, because of the holistic model we started with, whilst we adhere to the NICE guidelines where it is safe to do so for a patient, we offer very, very different therapeutic interventions within our service. All our team have supervision, monthly supervision. A senior management team have external supervision, and that is so important because some of the stories are harrowing for our staff here, and we have to be supporting our staff as well as the patient that comes to us. So outcome measures. We use 3 outcome measures. The Problem Gambling Severity Index, which is a measure out of 27 to measure how severe someone's problem gambling is. We use the Corten because most people that come to us have depression and anxiety. And we use, it was devised within the Holy Group, which I'm part of, a Cyclops. This is a quantitative measure to look at short, medium and long-term goals of patients. And we measure at the beginning of treatment, our therapists do it in the middle of treatment and at the end of treatment. And as I said already, from day 1, we have tracked every single patient. Don't get me wrong, we have did not attend. People do drop out, people's mental health gets worse, gets better, but we have to track everything, every single, and I think that has given us a proof of concept of the holistic approach to gambling harm. Okay, so the treatments we offer. So we are non-clinical care coordinators, which are non-clinical staff who will manage low-level patients, patients that need motivational interviewing, signposting. They will do some of our administrative work to GPs, mental health trust. They do relapse prevention, and at every stage we look at suicide and risk management. It's so important. And as you'll probably know, the NHS published in April that actually it's not acceptable to say someone's low, medium or high risk of suicide. So we're looking at that approach very differently now, especially within our risk meetings. So the therapies we provide are CBT sessions, 8 to 12 sessions. Psychotherapy for patients that are really traumatised. It's not a common thing, but we do use that because if you're tackling gambling harm, all the other things around that patient are staying the same, you won't move forward very quickly. We have specialist ADHD, because every single person we seem to be assessing these days seems to have some kind of autistic spectrum disorder. So we've got specialist ADHD therapists who do shorter sessions with some of the patients we see. We also run an ADHD group. We have trauma and PTSD. I think I've got that one. PTDS. Got it the wrong way around on my slide. I've just spotted that. We run women's groups, men's groups, mixed groups. We do EMDR too, and we do integrative therapy. And this is where it's decided at our multidisciplinary team. You may have someone thinking, oh, this is trauma therapy. When you dig a bit deeper, it is maybe integrative therapy opposed to that. And that's all, there are referral routes. That's not everyone on there, but that's our referral routes. But we have more and more healthcare professionals referring in, citizens advice, GPs, particularly mental health trusts. I've seen a real rise in mental health trusts referring to us too. So we also offer the same support for those affected by gambling harm. We don't differentiate. Our assessment process is slightly different, but we do not differentiate. Whatever support we'd offer the person suffering from gambling harm, we would for the affected other. That will also go through a multidisciplinary team process. And we have an affected other group. So our groups have been proved to be really, really beneficial. And in terms of accountability, we're very clear of where accountability stops. Sometimes people want to stay in groups. We look at aftercare with our third sector providers. We direct back to local services. And as I said, a lot of the work that the nurses do with their coordinators is liaison work. And that liaison work is vital in keeping patients safe within the service at the time that they come to us. So at discharge, we're going out back to our third sectors. They are allowed to stay in the groups. They're followed up at 1, 3, 6 and 12 months. We look at relapse within there, and we've got a really good system of following them up to ensure that we can get them back into services or to the right services should they relapse. So our discharge process is done mostly by our non-clinical care coordinators who are highly trained, and they source other activities for patients should they be needed. And whilst it's a bit small, this slide, but over 5 years I've tracked every patient, and you can see the starting scores. And so we've got an average of a reduction from a starting score of 20 out of 27, some months it's much higher, to a finishing score of 6.2. That's in my first year, and an average starting score in its 20s for core 10, with an average finishing score of about 10 to 12. So as I said, the data we've tracked, we've really been meticulous in tracking our data. because we do feel a holistic approach is really important. We know what the latest guidelines say, but this has worked for the patients we've seen. And as I said, in year 1, I think we saw about 4 patients. We're seeing 70 a week now. So very proud of the team and the service, and working with our third sector colleagues, our NHS colleagues, for the last 5 years. So, any questions from anyone? Hello?
Hi, you mentioned the 5 P's of gambling.
Yes.
Could you?
Yes, the precipitating factors. Emma, you might have to help me out because I might not remember them all. Pardon? Presenting factors, precipitating factors. Predisposing. Protective. And our last one, and I always forget our last one. So we're using that as part of our assessment process now. My mental health nurse, do you perpetuating factors. So we're using that as part of our assessment process now. So each section of our it makes it very succinct when you're feeding back at a multidisciplinary team to be following that process. And that is what's been recommended through the NHS new guidelines on suicidality too. And so that's what, and we're forever changing. When I look at version 1 of our assessment form to version 14 that we're on now, we're changing with the research that's coming out with the different models of care that there are. Okay. Any other questions? Hello?
Me again. How aware are GPs of the service that you provide?
How aware?
Are GPs?
Emma's just about to talk about that next. I'm not going to answer, Emma will answer. So she'll be talking about all the work she's done with the GPs over the last 5 years too. Any other questions? Hello?
You operate primarily in the London area?
No, nationally.
You are national?
Yes.
Already national?
We're national. We take from Scotland and Wales. At this moment in time, as part of the NGSN, there's a lot of change going on, as you might or might not know. So it hasn't been decided where services sit going forward from 31st of March as yet.